So when we talk about movement disorders, we have to understand the anatomy of the basal ganglia, because basically movement disorders are a problem typically in the basal ganglia. So basically the basal ganglia is group or ganglia is a plural. One is basal ganglion. So they are a group of deeply seated nuclei in the brain. So if you look at the next slide, this is a coronal cut through the brain. Now the yellow structure here, you see the cursor, right? بشوف الكرسر شكل
دكتور دكتور الكرسر واضح.
So the yellow structure is the thalamus. This is not part of the basal ganglia. However, it is heavily connected with the basal ganglia. Now, the structure of the basal ganglia includes this brownish structure. This is the caudate. This is the lateral ventricle here. This bluish, light bluish is putamen. Now, the caudate and the putamen, we call them both, the combination, we call it striatum. So the striatum is the combination of putamen and the caudate. Now, this is globus pallidus, the deep blue. So you have globus pallidus externa, you have globus pallidus interna. This structure is called the lentiform nucleus. So it's basically the globus pallidus with the putamen. Now, the light green here is the subthalamic nucleus, which are part of the basal ganglia. And the deep green is the substantia nigra, which is located in upper midbrain. So if we go back to the slide, the caudate nucleus, putamen, globus pallidus, subthalamic nuclei, and substantia nigra. These comprise the basal ganglia. The globus pallidus, حكينا, divided to globus pallidus externa and interna. And substantia nigra divided into pars compacta and pars reticulata. Now, most of the basal ganglia involved in facilitation of the movement. However, it has other functions, including facilitation of extraocular movements, and it plays also a role in cognition and emotion. Now, when we talk about movement disorders in general, we talk about either hypokinetic disorders and hyperkinetic disorders. Here, we're going to focus mostly on the hypokinetic disorders, namely Parkinson's disease and Parkinson plus syndromes, and in addition to the other mimickers of Parkinson's disease. Now, to understand Parkinson's disease and other movement disorder, we have to understand the pathophysiology of the basal ganglia. Now, the neurons in the basal ganglia connected to each other and to other parts of the brain through neurotransmitters. I mean, that's how neurons talk to each other. They use neurotransmitters. Now, the main neurotransmitter that functioning in the basal ganglia is dopamine. So it's mostly secreted from the substantia nigra compacta. That's where dopamine mostly stored, and that's where it's secreted. So it exerts effect on the striatum. As I said, striatum is the caudate and the putamen through either D1 receptor, which is stimulatory or excitatory effect, or inhibitory effect on the D2 receptor of the striatum. Now, the excitatory, this pathway, we call this the direct pathway. This is the direct. And the inhibitory, this is the indirect pathway. Now, the net effect of the direct and indirect pathway is the stimulation of the cortex. So let's take the direct pathway, for example. So substantia nigra compacta secretes dopamine that attaches to the D1 receptor in the striatum, and it stimulates the striatum. Now, the striatum inhibits the globus pallidus interna and substantia nigra reticulata. That inhibits the thalamus. So inhibition of the inhibition is a stimulation. So the net effect stimulation of the thalamus, which in turn stimulate the cortex and facilitate movement. The same token with the indirect pathway, but it's a different pathway. Now, what happened in Parkinson's disease and its related disorders, we have loss of dopamine from substantia nigra compacta. So what happens? You have less excitation of D1 receptor and less inhibition of the D2 receptor and the striatum. The net effect would be more inhibition of the thalamus, as you see, more inhibition. And the thalamus stimulates the cortex. So as you see, with more inhibition of the thalamus, less stimulation of the cortex and reduction of the movement. And that's what we call bradykinesia. Brady in Latin means slow, kinesia, motion. And that's the hallmark of Parkinson's disease and its related disorders, bradykinesia. Now, this is a cross-section of the midbrain. This one from a subject who died from other than Parkinson's disease. This subject advanced Parkinson's disease. This brown stain is for, anybody? What this brown stain for?
Substantia nigra.
Dopamine. This stain is dopamine. This subject does not have Parkinson's disease. As you see, dopamine is there. This is substantia nigra, yes. Now this patient with advanced Parkinson's disease postmortem, as you see, there's depletion of the dopamine here. So when we're talking about Parkinson's disease, we have to define it first. So it's a progressive movement disorder characterized by bradykinesia, as I just said. Slow kinesia motion, slow motion, slow movement. Patient also has resting tremor, rigidity, and I mentioned the morning rigidity to the morning group. As you remember, rigidity is a form or a sort of hypertonia. And anybody of the morning group can define what other forms of hypertonia can be seen also. I mentioned that in the morning. شو بيعمل hypertonia other than rigidity? ونسيتوا؟ وين الجروب المورنينج جروب؟
upper motor neuron lesion بيعمل
spasticity, absolutely, because hypertonia in the form of spasticity. This is hypertonia in the form of rigidity. This is extrapyramidal. That's pyramidal or the spasticity, upper motor neuron disorder. Yes. And typically in advanced Parkinson's disease, not early on, in advanced idiopathic Parkinson's disease. And remember this, idiopathic, but not Parkinson plus syndrome, idiopathic Parkinson's disease, there will be loss of postural reflexes that leads to fall. But that's advanced Parkinson's disease, idiopathic Parkinson's disease. Now, with Parkinson's disease is more common in males, and the prevalence increases as we get older. If you look at this cohort, the age group 40 to 49, about 41 per 100,000. However, in the age group above 80, almost 2,000 per 100,000. So as we get older, the more likelihood that we will develop Parkinson's disease. Now, for example, stroke, patient comes with focal weakness and loss of sensation. They might have speech difficulties. So you examine them, you talk to them, you get history, you examine them, then you think this is probably stroke, could be other differential like demyelinating disorders or hemorrhage or whatever. Then to confirm the diagnosis, you do MRI of the brain, for example, or CAT scan, and you might see it. So that's confirmed by a test, either MRI or a CAT scan. Anemia, for example, patient comes with symptoms of, for example, easy fatigue, dizziness, they're pale, you do blood count and you find low hemoglobin. That's confirming the diagnosis. Unfortunately, in Parkinson's disease and its related disorder, we don't have this luxury that there is a test that can be performed to confirm the diagnosis. So we have to rely on clinical diagnosis. So basically, you have to rely on your history and on your exam. There's no single test that can diagnose Parkinson's disease. So this is why we had criteria to follow. If the patient meets the criteria, then he or she would be diagnosed with idiopathic Parkinson's disease. One of the major criteria is the presence of bradykinesia. So every Parkinson patient should have bradykinesia with either one of the following, either resting tremor or rigidity or postural instability. Now, the patient also has to have three of the following. Unilateral onset. So as I said earlier this morning, typically with idiopathic Parkinson's disease, it starts unilaterally. And as the disease progresses, it might involve the other side of the body. However, the first side affected will still exhibit more signs and symptoms. Now, response to levodopa. Levodopa is a precursor for dopamine. So once it reaches the brain, it will be converted to dopamine. the missing substance. What happened in Parkinson's disease? We have loss of dopamine or reduction in dopamine in the substantia nigra. Levodopa-induced dyskinesia, we're going to talk about that, and a long course. We'll talk more about this dyskinesia down the road. Features of Parkinson's disease: micrographia, small handwriting; hypophonia, low pitch sound; hypomimia or mask face; loss of facial expressions, again due to rigidity in the muscles of the face. So you can read the patient. You can't tell if the patient is angry, the patient is happy, fearful, or whatever. They will have also hyposomnia or anosmia, either loss of smell or decreased smell. And this feature can predate the diagnosis of Parkinson's disease. And so constipation. Decreased blinking frequency, again due to rigidity in the muscles of the face. Loss of postural reflexes leading to falling down typically occurs later in the disease. Talking about idiopathic Parkinson's disease. Now we're going to talk about a condition that mimics Parkinson's disease, we call progressive supranuclear palsy. Patients, they are present with early falls. But idiopathic Parkinson's disease, typically the falling happens later in the course of the disease. The tremor is typically slow to moderate in frequency, not the fast. So anywhere from 4 to 6 or 3 to 6 hertz. Distal pill rolling, more resting. So this is a key feature, resting tremor. What that means, resting tremor? It's more clear, the tremor, when the hand is at rest, or the arm at rest, or the patient at rest. Now, the minute the patient starts moving the arm, trying to, for example, trying to reach something, the tremor will subside. So although it might be obvious to the observer, it's the least that affects the patient function because it does get better with movement. When the patient eats, drinks, writes, typically it gets better. Does not disappear though, but it can get better. And the tremor improves or disappears with purposeful function, as I mentioned. The tremor can involve the legs, so not only the arms, can happen in the legs and happen in the head, lower jaw, lips, chin, and so on. Non-motor features like constipation can be prominent and can predate the diagnosis of Parkinson's disease. It can be one of the earliest features of Parkinson's disease before the motor manifestations. Shoulder pain, pain-related dystonia, and specific sensory symptoms or paresthesias. Urinary frequency, urgency, or nocturia, which is urination at night. This typically does not happen early in the course of the disease. It happens later. Now, if you see early neurogenic problems, rethink your diagnosis. Probably we're not dealing with idiopathic Parkinson's disease, deal with one of the mimickers like multisystem atrophy. We're going to talk more about this later on. Orthostatic hypotension, another autonomic feature. We see it with multisystem atrophy, but it can happen in Parkinson's disease, but again, not early on. REM sleep behavioral disorders. REM sleep, that when we dream. Now, about 20% to 25% of our sleep, depends on the age, is REM sleep. Rapid eye movement sleep. What happens during REM sleep? The eyes move fast. What we call rapid eye movement sleep. And that's when we have the dreams. Most of our dreams, the complex dreams, occur in REM sleep. Now, as a protective mechanism, during REM sleep, we lose the muscle tone. So you don't act out your dreams. So if you have a bad nightmare, somebody's chasing you with a knife, you're not gonna punch the patient or try to get out of the bed and run, because that might cause injury when you're asleep, of course, trying to get out of the bed. So you have atonia or loss of muscle tone. So pretty much you're not moving. However, in these patients, unfortunately, in advanced Parkinson's disease, not only Parkinson's, we see it with other synchronopathies like multiple system atrophy, we see it with other degenerative brain disease. They lose this protective mechanism. So if they have a bad dream, they might get out and they might injure themselves. Neuropsychiatric symptoms can happen, again, typically a few years after the onset, like depression, anxiety, and panic attacks. Now, cognitive decline can happen in Parkinson's patients. Ultimately, about 50% of them might end up with dementia. But that's, again, later in the disease. Now, if the patient present early on, from the beginning, let's say within 1 to 2 years of the onset of the disease, with bradykinesia, and rigidity, and they have cognitive impairment and hallucination, rethink your diagnosis. We're not dealing with idiopathic Parkinson's disease. We deal with one of the mimickers, and specifically Lewy body disease or dementia with Lewy body, the same. So these patients, they present with early Parkinsonism in the form of rigidity and bradykinesia, with early dementia and cognitive impairment, and early hallucinations, especially visual hallucinations. Now, most cases of Parkinson's disease are sporadic. However, there are familial cases, genetic, and we see it mostly in young. And there has been genetic loci identified in familial Parkinson's disease, like the alpha-synuclein gene mutation. Sorry. Can you see me? Can you still see me? See me the slides?
Yes, yes.
Oh, something popped on my screen. So alpha-synuclein PRK1 gene mutation can lead to early Parkinson. Typically, these starts early in their 30s and 40s, and so the Parkin PRK2 gene and the leucine-rich repeat kinase 2 mutation. So these familial Parkinson tend to happen earlier. So most of the time, you see Parkinson above age 60, right? But in these patients, you see them in their 30s and 40s. Treatment. How we treat Parkinson's disease. I'm not going to spend much time, just to give you an idea. So what's missing is dopamine. So if you give dopamine, it will be metabolized in the peripheral circulation and cause a lot of side effects. So basically, they came up with a precursor for dopamine, namely levodopa. So this levodopa is precursor that be metabolized by dopa decarboxylase to be converted to dopamine. Excuse me. However, if you give it again peripherally by mouth, a good chunk of it will be metabolized in the peripheral circulation, cause side effects and decrease efficacy. So they came up with a molecule called carbidopa, combining to levodopa to protect it from metabolism in the peripheral circulation. However, when it reaches the brain, this carbidopa will let go. Levodopa will be metabolized by the dopa decarboxylase to secrete the dopamine. The brand name for this medicine, carbidopa, levodopa, what we call Sinemet. Excuse me. One of the oldest medication for Parkinson's disease. And you see a robust effect. You start patient on Sinemet, a few days later, you see a big difference in patient. You know, they improve pretty good. However, this medicine, the effect does not last forever. Unfortunately, at the beginning, we have this honeymoon period, works great. You give it 3 times a day, works nicely. A few years later, then the patients start running into problems, 5, 6, 7 years later. Then you have this half-life will decrease. Instead of, let's say, covering 6 to 8 hours, will start declining to 4 and 3 and 2 hours. So the patient will go in what we call the off phenomenon. So if you give 3 times a day, say one you give one at 8 in the morning, used to work until 2 in the afternoon, 5, 6 years later, that won't happen. So by 12 or by 11, the medicine wears off, and the patient will be off, rigid, not able to move. So you have to frequently dose it. You have to give it more, escalate the dose, and give more frequently. So you have to give it 4 times, 5 times, or even 6 times a day. Then you run into a different problems, what we call dyskinesias with this medicine. Again, that's later, 7, 8 years later. Patients start having these abnormal, unwanted movements, like turning the arm like this, or the head like this. We call these dyskinesia, unwanted movement. And typically happen at the peak of the dose. Let's say a patient takes the dose at 8, by 10, 11, you start seeing these dyskinesias when the medicine is working. This is why, because of this limiting factor, although it's most effective medicine, this Sinemet, carbidopa, levodopa, but because of these limiting factor, we came out of the scientific committee or scientific, or the big pharma came up with different medication to tackle these issues. One of them is the dopamine agonist. So these molecules, they work directly on the dopamine receptors, especially D2 and D3. However, they are not dopamine, but they work on the same receptor. We have several examples. One of them, pramipexole, we have it in Jordan. Roperidone, we don't have it. Rotigotone and others. Mostly these, they have good effect, but they have some side effects like sedation, impulse control, and others. Other class monoamine oxidase inhibitors like rasagiline and selegiline, they have modest effect, mediocre effect at best. The same with COMT inhibitors like entacapone. This is used mostly to enhance the effect of carbidopa, levodopa. So it's given in combination and potentiate the effect of levodopa, carbidopa by about 30%. Anticholinergic, they help mostly the tremor, like Artane or trihexyphenidyl. However, they have a lot of side effects, especially in the elderly, like confusion, dry mouth, dizziness, urinary retention, and so on. So we don't use them as much nowadays. Amantadine, another medicine that has modest effect, not robust, modest effect, but also can be used for the dyskinesias. These dyskinesias that we talked about, amantadine can help. So it can help Parkinsonian symptoms to some extent, a little bit, can help the dyskinesia. So it's not uncommon that you see this amantadine given later in the course of the illness when there are dyskinesias. So we talked about these younger patients. Typically, we try to delay the levodopa. So a patient comes to me age 30, 40 with Parkinson. I try to start with others like rasagiline, selegiline, or the dopamine agonists like pramipexole. However, ultimately the disease will progress and we have to use the Sinemet, the most effective medicine. Now, most of the advance lately in the treatment of Parkinson's disease has not been with medication. It has been rather with surgery. So we have this, what we call deep brain stimulator. So basically a small chip inserted deep in the brain, either close to the globus pallidus interna or subthalamic nucleus, and stimulate these structures. A small chip connected with wires that come out from the skull, and this insert in the skin all the way attached to big beta here, the lateral side of the chest, and give this electrical impulses every so often to stimulate this part of the basal ganglia and help with the Parkinsonian symptoms. Now let's shift gear and talk about some of the mimickers of Parkinson's disease. So we talked so far, we have talked about idiopathic Parkinson's disease. Now we're going to talk about mimickers that they look like Parkinson's disease, but they're not. We have a group of conditions, we call them Parkinson plus syndromes. So these disorder, they do have some Parkinsonian features, namely bradykinesia and rigidity, in addition to something else, and that's why we call them Parkinson plus syndrome. For example, we have PSP, progressive supranuclear palsy. So in these patients, they do have bradykinesia, and they do have rigidity and some tremor, mostly bradykinesia and rigidity, not much tremor. In addition, though, they have early gait problem. As I said with Parkinson's disease, idiopathic Parkinson's disease, the gait problem starts later in the disease. Here, it starts from the beginning, within a year to two of the onset of the symptoms. And patient will present with early falls, basically. One of the key features to diagnose these patients, they have restricted vertical gaze. They have trouble looking up and down. They also have cognitive impairment, and they do also have personality changes. Now, typically with Parkinson plus syndromes in general, the condition is less asymmetric, meaning it starts both sides of the body at the same time. As I mentioned, idiopathic Parkinson's disease typically starts one side and then cross over to the other side. And it maintains the unilaterality, meaning that the first affected side will still have more signs compared to that. But in the PSP and other Parkinson plus syndrome, they are less asymmetric, more symmetric, basically. And they share the feature that they have poor response to levodopa. Now, with one of the diagnostic features of Parkinson's disease is response. If you remember, going back to one of the slides, we mentioned good response to levodopa. Now, these patients do not respond to levodopa. So if you are like in dilemma, you're not sure this is Parkinson's disease, idiopathic, or one of the mimickers, Parkinson's plus, you give a good dose of levodopa, reaching like 1,000 milligrams a day, for example. If they have a good effect, good response, that's goes with Parkinson's disease. But if they don't, that goes with Parkinson plus syndromes. Because sometimes the picture is hazy and it's not clear to distinguish these conditions from each other. Now, another one, multiple system atrophy. That's another Parkinson mimicker. So these patients would have bradykinesia, they would have rigidity, they might have tremor, and they would have also autonomic dysfunction. Now, these features, the autonomic dysfunction, will start early in the course of the disease. So the patient would have early orthostatic hypotension, early incontinence, early impotence, and so on. Now, Parkinson patients, they might have these features, but later, not from the beginning, not early on. Now, we have other entities, we call them secondary Parkinsonism. Patient would have a disease that ultimately can cause secondary Parkinsonism. There are more than one condition that can cause. One of them, the post-encephalitis, been seen with influenza, West Nile virus, Japanese encephalitis, and prion disease. Vascular Parkinson due to multiple strokes, typically lacunar strokes deep in the basal ganglia. Drug-induced, we see it mostly with antipsychotic medications, especially the old generation antipsychotics, like Haldol, if you remember from psychiatry, haloperidol, the brand Haldol, bellarine, even the newer agents like abiprazole, risperidone, all these long-term use can lead to Parkinsonism. And typically it's more or less symmetric, more or less rigid, akinetic, decreased motion, bradykinesia with rigidity that's symmetric, not much tremor. We see it also with antiemetics like metoclopramide, promethazine, and so on. Not much with the newer agents like ondansetron. Manganese toxicity can also cause damage to the basal ganglia and end up with Parkinsonism. We see this in Wilders and minors. Chronic liver disease also. Carbon monoxide poisoning caused selective damage to the basal ganglia and Parkinsonism, and so on. So we have red flags. If you see, you suspect Parkinson plus or secondary Parkinsonism, in contrast to idiopathic Parkinson's disease. One of the features here, these are the features. Like, for example, early onset of dementia. So a patient coming with bradykinesia and rigidity with early onset of dementia and visual hallucination, you think dementia with Lewy body or the other name, Lewy body disease. Now, early onset of postural instability, early falls with bradykinesia and rigidity, you think progressive supranuclear palsy. Early onset of hallucination or psychosis, again, dementia with Lewy body disease. Ocular signs like impaired vertical gaze, again, PSP, progressive supranuclear palsy. Pyramidal tract sign, vascular Parkinsonism. Early autonomic symptoms, multisystem atrophy, and so on. Now let's shift the gear and talk about other movement disorders. So so far we've done with idiopathic Parkinson's disease and its mimickers. Now we're going to talk about a different class of problem here, the tremor. So merely the problem here is the tremor. If you remember from Parkinson's disease, we mentioned that tremor is resting, i.e. it's more obvious when the patient is resting his or her hand. But when they are engaged in activity, eating, writing, it will get better to some extent. In the tremor disease in general, it's the opposite. They are more obvious with activity. So it's more postural tremor, more with holding the hand up, more with eating, more with drinking. We have a condition called benign essential tremor. Why we call it essential benign? Because it does not have other features of Parkinson, like bradykinesia and rigidity. Basically, they have tremor only. Essential, basically, is genetic disorder. The tremor is faster than the Parkinson tremor. So we're talking about 4 to 10 hertz. May involve the limbs, head, chin, lips, tongue, and even the voice. And one of the key features, they have head tremor with it. As I said, it's typically genetic and it's somal dominant. Has been linked to a polymorphism in the LING01 gene. One of the things we can distinguish this tremor from others is response to alcohol. I'm not saying that I'm advocating alcohol, but one of the features, patient who, in the West especially, they'll tell you when I drink alcohol, it does get better. The tremor. Treatment, we give beta blockers like propranolol or primidone. This cartoon illustrates how the tremor can affect function like drinking from a cup, and how it can here it improves with alcohol. This table summarizes the differences between Parkinson tremor and essential tremor. You can go over this by yourself. But the key features, as you see here, action or posture, here resting. And it's faster in essential tremor compared to Parkinson tremor. Now, physiologic tremor, every person has tremor. I mean, I do have a little bit. You do, if you hold your arms up, you have fine tremor, fast, which is normal. However, it can be accentuated by certain conditions, like if you're stressed out, you're preparing for an exam, if you're anxious, fearful. It can happen also with hypoglycemia. The key thing that can with hypoglycemia early on is tremor. Hypothermia also, you have the shivering and the tremor. Thyrotoxicosis can cause tremor. Pheochromocytoma, drug withdrawal, especially benzodiazepine, patient taking Valium, for example, 10 milligram 3 times a day. I'm sorry, 10 milligram 2 times or 1 time a day, and all of a sudden stops, they will have tremor. Alcohol intoxication or withdrawal. Beta agonist, like breathing treatment, they might have tremor. Rubral tremor, we're going to skip. Tourette syndrome, another movement disorder. Here, the main problem is the tics in Tourette syndrome. Tics a form of movement abnormality. We have two types. We have motor tics and we have verbal tics. Motor tics, like shrugging the shoulder, grimacing, closing the eye, moving the arm like this, and so on. Can be repetitive. Now we have also vocal tics, like hissing sound, barking sound, sometimes even obscene language. Now, typically in Tourette syndrome, the patient would have both verbal and motor tics in association with behavior and psychiatric problems, like attention deficit hyperactivity disorder or obsessive compulsive behavior disorders. Starts early in life, kids age typically. Treatment only if it affects function. Can start with non-pharmacological treatment like behavioral therapy. Sometimes we use medications like dopamine antagonists, like or anti-dopaminergics, like abeprazole, Abilify, Halidol, and so on. And clonidine can be helpful. Clonidine is alpha-1 agonist. It's centrally acting, used for blood pressure. Can be used also for Tourette syndrome at small doses. Wilson disease. Wilson's disease, storage disease, basically. It's excessive copper deposition in tissues, including the brain, the liver, and the eyes. So when it deposit in the brain cause movement disorders and cause dystonia, can cause ataxia and Parkinsonism, and can cause also tremor. Of course, in the liver might cause liver problem. In the eye would cause what we call Kayser-Frischer ring, and I'll show you a slide of that. How we diagnose it? There's reduced serum levels of copper binding protein, what we call cerebrosplasmin. And when we do 24-hour urine collection, there will be increased urine excretion. Kayser-Frischer ring, basically, this is slit lamp exam of the eye. As you see, you know the color of the copper. This is the copper deposit in the basement membrane of the eye. MRI of the brain can be helpful in these patients. You have the head of giant panda, eyes, nose, mouth, or double panda head. I don't know what they call it, panda. So eyes here, nose, and mouth. Huntington disease, another movement disorder, a neurodegenerative disorder. And most of the patients will have chorioathetosis here, in addition to dementia, psychosis, and cognitive impairment, and ultimately immobility and death. But the main thing we see as a movement disorder here are the chorioathetosis, or chorea, this haphazard movement that starts muscle group to moves to other. This MRI of the brain, a patient with Huntington disease, as you see, this is normal. There's the caudate and putamen here. They're atrophic, almost gone. Now, chorea not only seen in Huntington, can be seen other parts. So See it with other disorders like Sydenham chorea, which is autoimmune disorder after strep throat infection. Typically, we see it with young females. There are other forms of chorea. Hemiplegismus is like chorea, but it's more proximal, involving the upper arm of the thigh, and it's more flailing, violent movement. Typically, we see with parietal lesion. I've seen a few cases after stroke in the parietal region. Tardive dyskinesia can be iatrogenic due to medications. We see it with antipsychotic medication, more with the old one like Haldol, or patients have these orobuccal lingual movement, continuous. Acute dystonic reaction. Dystonia, this like gives you these sustained muscle, sustained posture due to muscle contraction, agonist and antagonist. Can be acute, can be chronic. Acute, you see it after exposure to anticholinergics, antidopaminergics, like anti-nausea medicine, Reglan, that's metoclopramide, or promethazine. We see it also with antipsychotics like haloperidol, abiprazole, and others. How you treat? You quit using the agent that caused it, and you might use anticholinergics like alierfine or Benadryl, or antihistamines. Antihistamine like Benadryl, alierfine, and Benadryl. Benadryl, the brand name for diphenhydramine. Dystonia, as I said, sustained contraction, agonist antagonist, leading to abnormal posture with repeated twisting movement. It can be focal, segmental, or generalized. Now, focals, they are not uncommon. The focal, not uncommon. You see them, we see like blepharospasm, these movement, hemifacial spasm like this, torticollis, where the patient comes like this. And we use, I use, for example, these patients use the Botox, botulinum toxin, or other forms of botulinum toxin for the treatment. Now, the segmental and generalized, more genetic disorder due to mutation in the DYT gene. Typically seen familial, it's been described in the Ashkenazi Jews. They have this gene mutation and they intermarry. Cervical dystonia, it's a form of focal dystonia, like I mentioned, this torticollis. One of the most common focal dystonias typically begins in adulthood. So the patient will like this, move his head like this, can be anterocollus or retrocollus. They have what we call sensory tricks. So on the head doing this, they put their hand on the chin and they can correct their position. Treatment, as I said, botulinum toxin injection. Task-specific dystonias like writer's cramp. Whenever they write, the hand does this. So musician cramp, they do this, violin does so. Again, treatment with botulinum toxin. Myoclonus, other movement problem. It can be seizure. You know, myoclonus, there's primary generalized epilepsy with myoclonus, but it can be non-epileptic. We see it like with organ failure, acute renal failure, acute hepatic failure. They will have these jerks, we call myoclonus. See them sometimes with narcotics, high-dose narcotics, like morphine and others. Okay, I'm gonna stop here. Any questions?
يعطيك العافية دكتور.
Okay. السلايدات موجودات على الاي ليرنينج وجود لك. يعطيكم العافية.
إن شاء الله يعطيك العافية دكتور.
علينا.
Thank you, doctor.
علينا.